One sip of coffee, literally.
The live stream.
One.
Cheers.
Well, I can't, you know,
This always looks like a swimming pool.
boiled with Zoom, I think, so that it becomes, it can be, yeah.
Doesn't it?
It's being,
Doesn't this image look like we're sitting around a swimming pool?
They do not because
Oh,
it's
no,
like
it's
house.
Even in the assembly?
There's a couple people in the Senate and the Assembly run. As in they can do like that. Not original stuff, certainly somebody else ran, but there's not that many singles. There's not that many singles.
Maybe as a former rep for commission, like thinking more about participation to go in politics,
Like Justin?
like Justin. I actually knew about him. That's the sad part of how it's like, oh wait, what happened to that guitar player? It's like, oh,
You now wants to be your city controller.
like, well then.
I'm not sure what the,
Yep.
like the
We're
format is. I think he's gonna do a thing.
Then we'll kick it
Okay,
off.
good.
You'll
Yeah,
speak.
yeah.
he always
I'll
does.
facilitate, I'll facilitate Q&A.
Okay. We'll do a thing. Okay.
So good afternoon, everyone. This is a conversation about, I'm James Davis, PSC president and faculty member at Brooklyn College. We're here for a conversation about the New York Health Act. We are fortunate to be joined by one of the innovators, the architects of the legislation, a gentleman by the name of Senator Gustavo Rivera,
You
PSC.
forgot my name for a second there, didn't it? So you have to stop.
I'm gonna tell you something about your name. For a long time, I thought your name was Gottfried Rivera because when I started working at CUNY, I kept hearing all about the Gottfried Rivera Act. Gottfried Rivera Act, the Gottfried Rivera Act seemed very compelling. So when I finally met Dick, and then I finally met Gustavo, I realized they were different people.
Yes.
Probably tells you more about me than it does about them. So Gustavo has been working for many years on the long-term project of this legislation, but this legislation as a path to improving healthcare and health outcomes for New Yorkers. At the PSC, we have a commitment to universal single-payer healthcare nationally. We recognize that the path to achieving a national single-payer universal health coverage is paved with speed bumps and pitfalls and many incremental, probably steps to get there. And the New York Health Act is an important component of that. And we also recognize that the New York Health Act itself has gone through many iterations and that its sponsors have attempted to be responsive to challenges, including and especially from organized labor. So I'm sure the senator is going to speak about that, and many probably of the frequently and maybe less frequently asked questions about the status of the legislation. So could everyone begin by joining me in welcoming Senator Rivera? Thank you for being with us today.
Thank you.
And Gustavo, after you speak, Jen will just
Yes.
facilitate a discussion and we can take questions and comments.
Absolutely. Well, first of all, thank you for having me, Mr. President. My full name, by the way, is Jose Gustavo Rivera. Now, you had the issue with Godfrey Rivera, but my initial issue was Jose Rivera is the John Smith of the Puerto Ricans. And as evidence of that, when I first moved to the Bronx, the assembly member there was Jose Rivera. My father's name is Jose Manuel Rivera. My older brother, Jose Manuel Rivera. My younger brother, Jose Javier Rivera. My dog, Jose Puki Rivera. Like it's a whole thing. So that's why I go by Gustavo. But it is a pleasure to be known. Godfrey Rivera. That's not it does not insult me because I miss that dude. Obviously, he was the chair of the health committee in the assembly for a very long time. Dick Gottfried. He was a great mentor, still a great friend, and he continues what I see in every single one of my colleagues who retires. He now looks more rested, more Like he looks like he had a great night's sleep last night. He looks energetic. Every time I see an ex legislator, I'm like, what you anyway. So thank you for having me here and hello to everyone in the room. I'm not sure if we have one or seeing myself is this is going to be terrible. I don't want to be looking at myself all the time, but I know we have folks online as well. So welcome to the folks who are online, whether we got 2 or 20 or 200, welcome. So what I'm going to do is I think I'm going to just do kind of some top lines about what the bill does. I figure that most folks are familiar with it, but I'll just go through some top lines about what the bill does, and then go into some of the difficulties that there have been in making the bill a reality, where we are right now. And I'm glad to know that my committee director Tony Kergaravat is on the Zoom there. Tony, say something just to make sure that we can hear you.
Hello.
There you go. So Tony is one of the things that that you always need to know as a good leader is that you have to surround yourself with people who are smarter than you. Therefore, that's why I have Tony and Flavia in the corner. So if we're required to take a deep dive into a particular part of the bill, the gentleman has it on. He has it right in front of him. We can dig down as deep as you'd like into it. So. And then obviously any questions that you might have, and we'll take it from there. Okay, so I believe that healthcare is a human right. I think that we're probably all on the same page there. The idea that healthcare is a human right, if anybody says that and does not support a project that actually gets us closer to it, it's kind of belied by that, right? We don't have a system that perpetuates that. We don't have a system that pursues that. Instead, we have a system, as we all know, that has profit at its core. And because it has profit at its core, it will never go to provide universal health care. Because even there are some folks who say that they want universal coverage. And making sure that everybody has an insurance product does not guarantee anybody care. Because having insurance does not say that it definitely makes you have a nice little card in your pocket that has a nice little logo on it, et cetera, but that does not guarantee you care. And all you have to do is just ask 2 or 3 questions of anyone in the United States of America to kind of get them to ask themselves about what situations they might have had in their own families or their neighbors or at work, et cetera, to just completely confirm that. If we have a system that has insurance companies at the core of it, we will never have universal care. So we need to move away from that. And this is a bill that does just that. This is a bill that would create a single payer system in the state of New York, guaranteeing every single New Yorker or any person who is employed full-time in the state of New York access to the New York Health Act, which means that they would have guaranteed care, comprehensive care, which would include dental, vision, long-term care, which would have no copays, no networks, no deductibles, no out-of-pocket costs. And the immediate question that a lot of folks ask themselves is, how is that even possible? And 2 responses to that. Number 1, it is not something that's impossible because it's basic. There's a version of it in basically every modern democracy in the world. It's true that it's not the same in Canada as it is in South Korea, as it is in Britain. However, in none of those places would you go broke for getting sick, which is what we have in our country. So the first answer is there's a version of it that exists everywhere, so we can absolutely do it here because they do it everywhere. And the second answer as to how, the immediate question is, how are you going to do this? How are you going to pay for it? How is this possible? It speaks to one of the challenges of getting this bill done, which is the fact that it's kind of built into our brains. Over decades, it has been pushed into our brains that the way to get healthcare is to get a good insurance product. And that has been one of the biggest victories of the insurance lobby. The fact that they're able to convince you, because they've been doing that successfully for decades. It is, you just got to get a good insurance product. You got to get a better job to get a better insurance. You got to have this, and that's one of the challenges that exists there. Now, this bill is a bill that ultimately would save us money and cost, because it would cost less. Why? Because if you take first of all, administrative costs in a regular, in a private plan. And it's wonderful to try to get these numbers from them because they do, whew, the type of magic that they play with numbers is something else. But assume that for a private plan, privately run plan, you got between 15 and 18 cents out of every dollar go to administrative costs overall. And that includes a whole bunch of things, but ultimately it does not mean healthcare. Insurance companies are not in the business of providing you care. They're in the business of denying you care. That is how they make their money. The way that I talk about it is that it's you can, and I've actually said this, I remember with a couple of like senior insurance people sitting right next to me, which is what it's the best way to do it, to have them right sitting next to me when I'm saying this. The way I think about it is, does everybody know the parable of the frog and the scorpion? So there's a frog and a scorpion on the side of a river, and the scorpion goes up to the frog and says, "Hey, I know you can swim. Can I get a ride to the other side of the river?" And the frog says, "No, I'm not. No, absolutely not. I'm not going to do that." He says, "Why not?" "Because if I do that, you're going to sting me and I'm going to die. I'm not going to do that." And then the scorpion goes like, "Dude, I would never do that. See, because I don't know how to swim. It's why I'm asking for a ride. So if I'm riding you, then and I sting you, we're both going to die." And the frog thinks about it for a second and says, "You know what? You're right. Let's do, you know what? Don't worry about it. Hey, let's do it." Gets in the river. Scorpion gets in the back. Bloop, 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 bloop. In the middle of the river, feels the sting. And as the frog is going down in the middle of the river, looks up at the scorpion and says, "Why would you do that?" And the scorpion says, "It's in my nature. The insurance companies are the scorpion. It's in their nature." Not in my version, sir, but good. You could definitely run with that. But my version is, it is in the nature of a profit-seeking entity to seek profit. And that does not, and so our job is not to blame the scorpion for being a scorpion. Our job is to take the scorpion off the frog and crush the damn thing. That is what I'm trying to do with this bill. Now let's talk about some of the things that have been challenging in it. There's one challenge that I spoke about briefly earlier, which is the idea that we have baked into our heads that the only way to get good healthcare is to get a good insurance product. And therefore, when you say to somebody, "I don't want to give you a better insurance product, I want to get rid of insurance companies altogether," it kind of, people have some issues kind of dealing with that, right? So that's kind of baked in. The other issue is that there are obviously folks who have a vested interest in maintaining the system that exists currently. And certainly we can talk about insurance companies, but also big private hospitals are part of the situation here. As much as I love my hospitals, there are even though in the state of New York, they are nonprofit by law, because you cannot have for-profit hospitals in the state of New York, they certainly operate like for-profit companies. And they kind of, rely on the fact that there's going to be, the private payers make up a good chunk of the amount of money that they're coming in. So the redesigning a system which eliminates that private payer, is not something that they want to do. But the other problem the other challenge that exists is, and this is where we get to organized labor, where there has been an issue. It was actually surprising to me that a couple of years ago, I've carried the bill for a few years, and it was surprising to me that there are folks it's not that we don't have unions that support the bill, as is obvious. I am in the room of a group that has been supportive of the bill forever, and I certainly thank you for that. The nurses have been supportive of it, CWA, 1199. There certainly have been unions who are supporters of the bill, but public sector unions have been resistant. Which is another reason why you are you are very special to me. By the way, I don't know if y'all know this, but I actually was a member of PSC.
Yes, you remember.
Right? Yes, I was a member. I came to New York in 1998 to do a PhD in political science at the CUNY Graduate Center. Started teaching as a graduate teaching fellow at Hunter College in 1999, and became one of the first class of adjunct members back then in 1999. So very, very much a fan of you folks as an institution. And even if I had forgotten that, you have reminded me how awesome you are by the fact that even in a room where other public sector unions who are resistant to this bill, you speak up for its importance. Now, and so the reason why they're opposed, I think that there's some folks who have a legitimate concern, which I call the bird in the hand problem. The notion that there is this, we have this, that we've negotiated. We know what this is. We have fought for this. We have given up so much to be able to have this. And you're telling us that we have to just give me something different. And so I think that there's a legitimate concern there. The response that I give to these folks is that it is true that I will never be able to give you back what you gave up to keep those benefits over the years. But what I can tell you is that when we move to the New York Health Act, you will no longer have to consider health benefits as part of your negotiations because they will be off the table. Because if you are a New Yorker or a fully employed person in the state of New York, a person who is employed full-time in the state of New York, you will be eligible to have the New York Health Act cover you. And therefore, all the benefits, which include, as I said, dental, vision, long-term care, no co-pays, no networks, et cetera, you will be included in that. And therefore, you will be able to negotiate for all sorts of other things. And what those are, I'll leave it to the negotiators to figure out what those things are. But if you didn't have to think about healthcare as one of the things that you had to negotiate for, you'd probably be able to get a lot of other things. But I think that there's also some folks who are resistant and because they want to maintain control of their own little space. And I think that what we've always done, and when I say we, certainly my colleagues, my colleague who was a sponsor before, Dick Gottfried, and now Amy Paulin, who's the chair of the Health Committee in the Assembly now, we've always had an open door to folks who want to, in good faith, engage with us about how to make the bill better. As a direct result of that, we actually did a couple of changes to it that relate specifically to concerns that were brought forward by public sector unions in the last couple of years. There's two changes that we made recently in the last 2 or 3 years to the bill that specifically relate to benefits and relate to to copay. So what you're currently paying and in many instances not paying. And we made those changes. In other words, we've always believed that and when I say we, I certainly am not speaking of myself in the third person, kind of in a royal we, but as in the colleagues of mine who have been sponsors of it and my staff, myself. We've always believed that the bill is clear enough in certain instances, but it needed further clarification according to some public sector unions, so we provided it in black and white. And we believe that the current version of it protects the benefits that you currently receive. It provides a higher floor regardless because, among other things, it doesn't have limited networks as well as include long-term care. But we still needed it in black and white, so we included it in the bill. It says that at the very least, you as a public sector worker would receive the amount of benefits that you receive now under a New York Health Act. Again, these are below what the New York Health Act would guarantee, but if you want that in black and white, we brought it to you, we gave it to you. And the second one, Tony, help me on the second one, as it relates to copays, correct?
Yeah, employer cost sharing. So it's right now the language in the bill is how the revenues are generated. It was at minimum 80% employer contribution. And I know a lot of folks, particularly in New York City, the employers are contributing 100%. And so the language was changed to state that whatever they were contributing before, they would automatically keep contributing that. So yep.
Yep. So those are the two changes that were made in black and white. Since there was always language in the bill that says that as it refers to the payroll tax, which is one of the ways that we finance it, that 80% minimum was the employer and 20% maximum was the employee. We believe that the original version already allowed for there to be some, for there to be a negotiation so that it could change. But if in certain instances, in certain contracts, there is no, the employer contribution is 100, so we wanted to bake it in there. And so it is baked in there so that if that is the case that you have now, that will be the case going forward. But regardless, it is a system in which no one would be paying copays or deductibles or out-of-pocket costs. And there would be just one network, the state of New York. So I'll just bring it in for a landing as I open it up to questions. Ultimately, I think that this is a bill, as I'd referred to it consistently, that it is both politically and technically it is difficult. It is complicated, but it is not impossible. And that is evidenced by the fact that, as I stated earlier, there is a version of a system that guarantees healthcare to every single person within a country in basically every modern democracy. You do not go broke for, if you get sick in other countries. That is not the case in the United States of America, and certainly not in the state of New York. So even though it is complicated both politically and technically, it is necessary for us to push through. The last thing I'll say is that I consistently refer to the state of New York as not having an opportunity, but an obligation. We not only have the population size, the tax, the way that our tax structure is, who our population is, the type of money that we could generate from putting from doing all of the things that we need to do to fund it, means that we have an opportunity to be able to present a version of this so that everybody in the country knows that it's possible. And I believe that we have an obligation to do that as New Yorkers. So with that, I will say thank you for having me, and I will answer any and all questions you might have. Sorry for this. Look, we do it.
Okay, so we're going to open it up to questions. Oh, you need a
Wait.
microphone.
I know there was a third one.
Got to run around.
There was a third one.
No.
Oh, it's so that they hear it, so that they hear it in the thing. Yeah.
Okay. Hi, thank you for being here and good
Yes,
to
ma'am.
see everybody. My question is, as a retiree and an active retiree with the union, and it's been a while since I've looked at the New York Health Act and Healthcare Act. And how does it handle Medicare? How does it interface with Medicare, or does it, and how does that work?
Well, the way that it interacts with Medicare is that we would put Medicare money and Medicaid money into one pot, as well as the payroll tax. So it's a payroll tax, the graduated assessment based on ability to pay. We put it all in one pot, and that is how we would pay for it. So as far as the benefits are concerned, you would be covered by the New York Health Act on everything, including things that are currently not covered under Medicare. So it would be, including long-term care, you would have dental, vision, et cetera. Like, it would be comprehensive, as well as drug benefit, all included. So in other words, it would be Medicare extra, I guess would be the best way to say it. Ultimately, it would not take anything away from you. It would add things to the things that you currently have available to you. If you're a resident, if you remain a resident of the state of New York, I should make that clear. If you're a retiree and you are in another state, then the benefits are the ones that were negotiated by a union in the contract that you will. So the benefits that you have, if you move to Florida right now, in the benefits that you receive based on your retiree benefits are what they are, depending on what the union contract says. If the New York Health Act was in effect, that would still be the case, because it doesn't have to do anything with what you get as a retiree if you're outside of the state of New York. If you're inside the state of New York, then you would be covered. I guess over there and then over.
Sorry. Oh. I wrote this out several times, so it's a little bit long, but I'm gonna
Okay.
try.
Go ahead, ma'am.
Put on my reading glasses. How will doctors, I have a lot of serious doctor stuff as a retiree after 46 years. Anyway, at NYU, and my doctors are all at NYU, HSS, NYPH, and Cornell Weill. And many doctors at those places do not accept traditional Medicare now. They have to accept some, and I've experienced that.
Yes.
So if this goes into effect, if I go to the same places and the same doctors, do they have to mandatorily take me as they would with the ones who were traditional Medicare? Doctors have expressed to me prior to any of this that they're really only interested in private.
By the way, when you're speaking on the
Private
mic,
patients in
just point it directly. Just point
and
it at you and you're good.
concierge medicine, they're not really interested. I had someone at HSS who was treating me for serious bone stuff,
Yes.
sent me an email and saying, you're no longer my patient, you're stable, some PA will call you. And it was complete false. But she had already expressed to me in her last pleasant conversation after 3 years that, traditional Medicare doesn't pay the bills.
Right.
And therefore, they're really only interested in private concierge medicine.
Yep.
And my other concern is I have lived and I have many friends in England and Canada and all of that. A friend of mine, when we were both in our 20s, had said, you wouldn't be happy because I get an appointment with my primary care group, no problem at all. She was getting very dizzy and had a young kid, and she had to wait 9 months for a specialist. What will this do? Can you predict what this might do in terms of wait times? I really believe that everyone should have coverage, and I've lived all over the world, and I'm horrified by what we do. How does it affect us directly as retirees living in New York? And the last very short one is, if I'm visiting California and get sick, visiting a friend, what happens when when New York Health Act comes in? What would that do to me visiting?
Okay. So in the first, there's a lot of stuff there. The first one had to do with doctors who don't take Medicare or Medicaid right now, right? As you said, a lot of it has to do with just doesn't pay the bills, right? So private payers are over here. Medicaid is garbage. The Medicaid reimbursement rates are garbage. I'm fighting for that constantly up in Albany. So Medicaid is over here. Medicare is over here. Private is over here. The bill would have language in it that would make it in statute that the rates need to be set as it relates to the cost of care. So that's something that doesn't exist anywhere in statute. There is a board that would manage the New York Health Act. There's no rates set in the bill. Instead, the board would have the authority to put the rates in, and the rates would have to correspond to the cost of care. And that means that it won't be Medicaid and it won't be Medicare. It won't be up here in private, but it'll be right around, maybe around here. So what you'll have is that places that are safety net institutions will immediately receive more money coming in because the people who they treat, if they treat, like, for example, St. Barnabas Hospital system in the Bronx, over 95% of the people who go there are Medicaid patients, which means they basically lose money every time somebody walks in the door. Get everybody to actually have the New York Health Act. Every single one of them will receive more reimbursement for treating those patients. In a place like NYU or in Mount Sinai, they oppose the bill because they have all these private payers over here. We will actually make it so that the only ones that will operate, the only type of insurance companies that will be able to operate, we're not banning insurance, but we are banning it for issues of medical issues. So we will have, basically everybody will be in one system. So you, me, the president of Colombia, if the Orange Madness, that guy in the freaking White House wants to live in Queens, or Manhattan, he should stay in Florida, the freaking guy. But regardless, every single person would have the same system and one network. So that's the first one. Do you have follow-ups on that one? Yes.
Art stuff, let's say.
Yes.
I'm still concerned with that everyone getting exactly the same treatment in terms of the financing.
Yes.
And I hear about tier medicine and people who,
Yes,
get treated.
right.
But if everybody is equal and the monies are equal, how does all of this, do I wait 12 months or do my doctors leave, or do
Well,
they close and become private hospitals?
So as far as wait times are concerned, so that
Wait times, and do they become private hospitals rather than not-for-profit hospitals, in theory?
Well, they're.
I don't know.
I got kind of confused there. Every hospital in the state of New York is nonprofit by law. You can't have a for-profit hospital in the state of New York. Again, many of them operate as if though they were for-profit institutions, but they are technically nonprofit, all of them. But as far as wait time is concerned, there are wait times in other countries, and there is likely to be an impact here based on but that has more to do with the fact that there's shortages of healthcare workers, regardless whether we're in the system that we're in now or not. When you have institutions that are better paid, like most of Safety net institutions that serve poor and working class folks across the state of New York would get paid better. They would be better able to maintain, to stabilize themselves as an institution, and therefore be able to treat people more quickly, be able to focus more on preventative care as opposed to sick care, et cetera. So I don't, and I'm sure, and Tony came off of, he put his camera on because I know he will add to this issue. So talk a little bit about the wait times issue, Tony, and about that first.
Sure. Yeah. Well, on wait times, I think you are correct, Senator, that much of the delays that we've been seeing now has to do with workforce shortages for healthcare professionals. As it relates to whether or not providers would accept the New York Health Act, there is nothing that explicitly forces providers to accept the New York Health Act, but it would displace other insurance options. So it would be the biggest and practically the only game in town. So there would be a strong incentive for providers to accept it, to have access to be able to treat the entire population of the state, to have them all basically be in-network patients. I think that some of the benefits for providers really focus in on administrative simplicity and competitive reimbursement rates. And I think that those are really the two strongest selling points for bringing a provider into the New York Health Act network.
And let's actually linger on that for a second. Give me 1 second. Administrative simplicity. I want you to talk to any doctor and ask them what kind of fights they have to get into with insurance companies to make sure that they get paid. I remember there was a conference that I went to just last week. And there was a guy he was a legislator, and I don't remember what state he's in, but he's also a doctor. He's a gastroenterologist. He says he employs 3 full-time nurse practitioners, but they don't do nurse practitioner stuff. The only thing that they do is fight with insurance companies for denials. They fight denials, and just thinking about that, that is the reality for many institutions. Because again, insurance companies are not the Scorpion is not in the business of providing you care. It is about denying you care, and a lot of times they build in denials like almost automatically, and then only a small percentage of people actually fight them because it's so difficult to do so. So they build it into their books. It's like, we're going to be making some money here because if we deny every single one of these procedures, only 2 of them are going to come back and are going to successfully be able to get it back. So we're going to make out of 10, we're going to make out of 8, So administrative simplicity and higher payments. Because again, we want to create a situation where there's literally only one network. Now, if somebody can pay out of their pocket, right now, that doesn't change in that instance. They'll be able to say like, I'm going to pay out of my pocket for whatever services they want. But we are creating a system that is equalizing as basically for everybody else. And particularly considering folks we're not even talking about poor working class people. We're talking about middle class folks, many of them union members, who constantly have to make decisions on things that might have nothing to do with their health and more to do with how much money they have in their pocket. You had some over here. Yes.
I'm going to try to keep this brief. I'm really happy that you've taken this on and the people that are supporting it. And it's quite amazing to see the level of support given all the adversities and obstacles. My question is, one, how ordinary people might perceive this in terms of what percentage of their income would be taken out in order to pay for this. So that's one question.
And I would rather answer one at a time.
Yeah.
So there are a few studies that have been done on this issue. None of them are very recent. Some of them are a couple of years old. We do have a group of economists that is doing an economic analysis that should be available before the end of the year. Excuse me. We've been working on them with them for a couple of years to kind of get a more current analysis. But the more recent one that we have was based off of the RAND study. RAND as in the RAND Corporation. I don't think anybody would describe the RAND Corporation as a crazy lefty organization. And what they found was that we would save somewhere in the neighborhood of something like $80 billion a year. So ultimately, and by the way, like 93%, I think, Tony, you might have the numbers in front of you, of New Yorkers would pay less than they pay now. Because if you do not have deductibles, if you don't have co-pays, if you don't have out-of-pocket costs, there's a whole lot of less money that that actually comes out of your pocket. So basically, the overwhelming majority of New Yorkers would pay less under the system than the one that they're currently in.
So it would seem to me that to make that case, there has to be like very specific literature with example, I'm just wondering the politics of it to be successful, it seems to me, have to be as specific as possible with examples. And the second issue is all the elites, including the hospitals, including the AMA, including the investors or the trustees, the medical institutions. It seems to me that we do require to rethink the relationship between doctors, nurses, et cetera, in terms of providing primary care and how many people we graduate that could take, really provide the kind of care that you're talking about. So the business community, do they benefit from this system? I mean, as long as we have capitalism, we have businesses.
So again,
how do
there's a lot there.
you approach this politically?
So I approach it politically one step at a time. And part of that means that every time that I meet with, because I'm the chair of the health committee in the Senate, which means that even the insurance companies, there's nothing better than sitting with insurance companies. They have to come talk to me. It's the best. But even when hospitals meet with me, every time that they bring up an issue and we work with them to fix it, 9 times out of 10, I can tell them, if the New York Health Act was in effect, you wouldn't have to deal with this bullshit, right? And so and then when you talk, for example, so you got the hospitals, there are many, basically safety net institutions around the state. The people who lead safety net institutions are all supportive of it. But the ones that lead the bigger institutions are not. And most of the organizations that they belong to are kind of a mix of one and the other. It is about the way that we do this has to become a political necessity, has to become a political inevitability. That takes time, right? Think about marriage equality. Marriage equality didn't happen overnight. It needed to be brought to a vote before the state Senate in New York and fail before it succeeded a few years later. And it needed to be built on. For years, it was something that was not even on the agenda. So we need to conversations like this are essential because I think, and I'm glad that you asked me this question, because for me, I think that the difference in the state of New York is organized labor. The reason why this bill hasn't gotten more movement in the Senate and the Assembly, which are both controlled by Democrats, is because when some of my colleagues came to me and said, I went to them and said, would you support the bill? And they got on it. Many of them went privately to places like DC 37 and UFT and said, hey, do you support this? Like, no, I don't. Okay, cool. Then we're not really going to move it. When you and there are breaks there, though, and I think that for those of you that are retirees in here that have been fighting the Medicare Advantage battle, bravo. Because I sincerely think that is the chink in the armor. Because the reality is that if this was in effect, if the New York Health Act was in effect, they would have never had to make this choice. I remember there was a DC 37 local. I don't remember it was a mid-sized local, and it was like about 2 years ago. I know that the winds are shifting. Because for many years, there were some folks who just sat down, and then when we became the majority in the Senate, all of a sudden, it became clear that passed in the Assembly for years, and I told Dick Gottfried, it's not going to pass in the Assembly this year that we're the majority in the Senate. And he's like, of course it's going to pass. And I said, Dick, prepare yourself. It's not. And it didn't. And it didn't because all of a sudden it was a possibility. It was a real thing that might pass in the Assembly and the Senate. So, and part of that were whisker campaigns of folks there were some folks, I have memos from years past of support from some large unions that are currently not supporting the bill because they would support it when it was something that might not become a reality, but now it is. So all this is to say, there was about 2 years ago, there was a meeting I had they requested it. It was a mid-sized local from DC 37, and they requested the meeting. And when I got on the meeting, it was like 10 of them. It was like all the leadership and everybody. And the one question they led with was, and I believe them. I took them at the word when they said, you know, that thing that we did with Medicare Advantage, we didn't want to screw over our retirees. We just thought we didn't have an option. Like, you might believe that to be true or not, but let's say it is. They said we didn't think we had an option to be able to maintain the fiscal soundness of the whole thing. We needed to do this. We needed to change the way that we did it because we needed to save some money. The question that we have for you, they asked, was if the New York Health Act was in effect, would we have had to make that decision? And I said, no. And we took a deep dive into the policy. So there is a crack there. And the fact that you have consistently won on this issue in the courts is a real positive thing. Because I think that, because I think it's it's a basic issue of like, you negotiated for the benefits, so you should freaking get to keep them. And that's, it was baked in. Bottom line, I do think that there is if I can get DC 37 or UFT, and I've been working on them day and night, and I think that there are some breaks there. If I can get either of them, this becomes a downhill battle. Then we go downhill because there's ways that this can become like when it becomes something that's a political necessity, we're going downhill. Over here, because you're like jumping over, and then
I feel
and then
like
over
this
here.
is now a follow-up question, if
Yes.
that's okay. Because my name's Andrea Vasquez. It's great to be here in this conversation. I'm the secretary at the PSC, and many years ago, maybe 5 to 8 years ago, I was invited to be part of a meeting which was all the New York City labor union leaders, and you were there, and Dick Gottfried was there, and you did a
remember those well.
presentation. Okay, I remember it too, and it brings it back now because what I was surprised about was the immediate response of unions saying what you indicated at the beginning. Will my members do better, or will my members stand to lose something? And the questions were, yeah, but we have really great dental. And another union, yeah, but we have really great mental health. And another union, but we have eyeglass, right? And they were concerned about the benefits, the real bread and butter things that we don't negotiate our health terms in our contract, but other unions, I mean, you know the deal. But everyone was concerned about their members losing something. And I guess you said before that now you have changed the language, so it's clear that you're going to get at least what you have now. But in these uncertain times that we're living in, I think it's more important than ever. I mean, people are not going to take a risk or feel they want to take a risk with something like their health care, right? If there's one thing they have that's secure, they have a plan, they have a union, they don't have to pay, what do you call it when you go each time? Co-pays. I mean, there are certain things that union members have and they cherish. So I guess in some way, I feel like it's even a harder question. How do you ensure people that they will have at least what they have now? I think and I have to say, as a longtime member of the PSC, we are also a visionary union. We fight for things that we don't think are easy to get, or that will come simply, or that will come without real fights and making you unpopular. We've been in those positions. So we want to be able to tell our members that this is going to work for you and you will do better, and the world, the city will do better. But how would you speak to that? In terms of, yeah.
Well, as far as the benefits, again, the language is there, and we can get you the exact site, so you can say like it's written in black and white into the law.
The language is going to be meaningful. I guess that
Because if it becomes then we just get into a question. If it becomes law, like it would be let me be clear about something else. That I am not. I've never promised. Unicorns and rainbows. Like, it's not the implementation of this. Once we get it passed, it's going to be difficult. The maintenance of the system is going to be difficult. The politics of the board, that there's going to be some difficulties and challenges there. But what I do argue, and I will die on this hill, is that it is illogical for us to believe that the current system that is designed not to serve us could in any way be better than one that is at the core, because it is written into law, designed with the patient in the middle. And yes, there will be difficulties. Yes, there will be challenges. Yes, there will be things that we'll have to figure out on a day-to-day basis. But that is a much better place to be. Also, there's an accountability there, because it will be something that is that's a publicly accessible thing. There will be board meetings. How many board meetings have you seen at United Healthcare? Like, broadcasts and like recorded so you can watch them over and over again? Probably none. I am a big believer in something that is a public good. If we push towards making it a public good, and I think that it is, and again, I keep using the word obligation. It is not just an opportunity that we have, it's an obligation, particularly in the times that we're living in right now. It is a challenge. This is an incredibly challenging thing, not just getting to the top of the mountain, because getting to the top of the mountain and resting once we pass the bill, then the fog will clear and we see we'll have another mountain to climb to make sure that the implementation of it could be done well. And once the switch is flipped, that the thing is working. But again, keeping a system that at the core has profit will never, ever, 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 ever serve us. And so we have to move away from it. And I believe that this is the way to do it. And again, I think that the difference will be made when we get those public sector unions to turn. Because I've always called it, I'm building for the turn. We're taking the train and it's picking up steam, and it's very slowly picking up steam, but it's picking up steam. And I want to get to the turn to be like, there will be a moment when we're going to turn and we're going to go really fast. And if you want to be on the train, now's the time for you to be on the train. Because if not, you're going to get left out, and I'm not going to look behind me. But for the moment, the train is still not picked up enough speed, so you can get on and figure out how we can move it together. So now we have something over here.
You're already at the point where I had a question.
Okay.
And I'm thinking back to when Bill and Hillary Clinton got bloodied.
Yeah.
When they tried to change healthcare. And the debate on TV was about the quality of American healthcare.
Yeah.
And the Clintons were not willing to say, if we take the profit motive out of it, we solve the problem of health financing. This
absolutely.
was never a question of health care. The
That's
United
right.
States has the same standards that Canada has, or vice versa. But our health care is more expensive because there's a profit motive. The problem is, how do you make that case to the American people and not be labeled Mao Zedong's descendant? That is to say, when is the profit motive good, and when is the profit motive
I'll tell you, the way that you do it, one of the reasons that I think that I'm not sure what position you folks have taken in the mayoral, but there's a point here. The reason I think that Zoran has been successful so far is because regardless of whether you can call him a socialist or you can call him anything, but it's not a god, right? The fact is that the things that he is talking about have to do with real people's lives, real people's experiences, and then he's talking to those experiences. And I believe, and I've had this conversation about healthcare, and I've had this conversation around addiction and overdoses too, with some of the most conservative people in the country. So I belong to different organizations like National Council of State Legislators, National Association of Latino Elected Officials. So I've been all over the country, different conferences, and I've had one-on-one conversations with some of the most conservative Trumpites, and still can make the case to them, do you sincerely believe that the healthcare system serves you or your constituents? And have them agree. So I think that the way that we do it is certainly, we have to be insistent, we have to be persistent, and we have to recognize that the shit is a struggle. It is not an easy thing because there's some deeply, deeply held, not beliefs, but deeply held perceptions that have been put there by the profit-making organizations. Like the insurance companies build it. You just need a better insurance product, Papi. We just need to make sure everybody's insured. That would make sure this is the battle that I have with them all the time. The insurance companies, like when they come to me, and by the way, the lobbyists that they have in Albany, I really hate the guy because I like the guy so much. He's actually such a nice, sweet dude. And I tell him all the time, it's like, why do you have to, could you be an asshole, please? But still, you're just a nice fella, but you work for some evil bastards. So he just smiles like, anyway, but would you do it through, you have to be persistent, you have to be insistent, you have to connect with people without connecting to an ideological, like putting an ideological tag on it. It's just asking basic questions. And what I do is like, tell me about do you have older family? Tell me about the situations that you had there. Have you ever had a situation where your kid was sick and you had to bring him to the hospital for asthma over and over again? Like how many times have you made a decision to get in an Uber and not get in an ambulance, even though you have you're bleeding because you figure it's going to be a lot less expensive if I get in an Uber and I have to pay to clean up the blood in the back as opposed to getting a freaking ambulance. All the things, if you speak to people's real situations and you insist to them like, we can change that. we can make this different if we change the basic, the perverse incentive in the middle of the system. And this is the thing about the current system, regardless of whether you have good actors in it or not, because the perverse incentive at the core of it means that they have to make decisions that refer to that perverse incentive. So, like, for example, whatever you feel about Montefiore, it's a big, big organization. It's one of the big, and it was a hospital and a hospital system that expands all the way to Newburgh. And the reason it expands all the way to Newburgh, even though the basis of it is in the Bronx, is because over the last administration, that piece of human garbage, Cuomo, one of the things that his human garbage administration did was encourage smaller independent institutions to cease to exist and just to join bigger institutions, right? And there was a whole bunch of them all the way up to Newburgh that Monty picked up with the promise that the state made that we're going to take care of you in the back end, which were broken over and over and over again, so much so that when the leadership in Monty changed, they had to make some internal decisions like, we can't keep, there's some places that we might have promised that we were going to try to get in, but we can't expand further. We got to figure out how we can maintain our standards right now. Sometimes they made investments in parts of the system which served more private payers than some of their Medicaid patients. And Medicaid patients like honestly were like, what are you doing? You're spending money over there. And yes, they were, regardless of who the actor is, they had to kind of do that to be able to get more private dollars so that some private payers so that they can stabilize the fact that most of the people that they serve are Medicaid patients in the rest of the system. So you see what I'm saying? We have to fundamentally change the parameters there. And I'm sorry for the soliloquy, but go ahead.
My question is about. La 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 la.
Go ahead.
We're here all night.
Yes.
How would you deal with probably a very specific DC 37 question about members losing jobs as a result of the difference in the administration, or like I'm thinking about people who do, I'm sure you've thought that through. I haven't read every single thing,
Yep.
so maybe that's very obvious.
So a couple, no, it's not. And I'm glad you asked. A couple of things. It is obvious that there would be a shift, and that some folks who are responsible, not just for the administration, but certainly folks who work in insurance industry, there are some changes that will have to occur. Number one, there will be a shift, and because there needs to be a growth in parts of the administrative apparatus inside the state, then some of those folks could actually transition to do that inside the state. That's number one. Number two, there's actually language that we put into the bill that relates to retraining, and there's actually there's retraining money, and we worked on that language with 1199, who has a lot of experience over the decades in transitioning from one type of healthcare worker to another and training one workforce into it with some skills so that they can do the new job, et cetera. So we do have some language in there. But third, and most importantly, if folks are losing their job, while they look for another one, they will have health coverage because they're New Yorkers. So, I mean, there's probably going to be some fall off and some folks that have to transition out of the current job that they're in because it will no longer be necessary, or it will transition to something else. But and the last thing is the type of economic activity that will be generated. That's another calculation that Rand made. Tony, see if you can track that down as far as the economic activity that they calculated would be created because of the New York Health Act. Do you have that? Yeah, you're unmuted. Go ahead.
Sorry. So I don't have an exact percentage, but it was outlined in there that it would increase overall economic activity in New York State as a whole, exactly for the reason that you spoke to, Senator, that folks would not lose health insurance because so much of it is dependent on employment, that it would result in more people engaging in entrepreneurship, or the freedom to sort of move around from job to job without fear of losing their health insurance. So I don't know that there was an exact dollar amount that was put on it, But it was a factor in their calculations as to the overall economic benefit to the state.
Thank you.
My thought is that if it's could be made specific, just like with the green jobs transition, it's union jobs that we're looking for, unionized jobs. Same thing here, that there'd be more unionized jobs
Certainly.
that
Yeah,
would be
yep,
available.
if they're in the state for the apparatus that would be required to operate it, then those would be
And
absolutely unionized jobs.
And please come speak in my class. I have a
Okay.
lot of, this is completely inappropriate. Everybody else shut your ears. But I have a lot of DC 37 members who I work at the School of Labor and Urban Studies. And I'm covering this in the fall.
So I would, no, listen.
I could be
No,
so
it's not, no, it's not
over
inappropriate.
someone.
No, it's not inappropriate at all. It just has to do with schedule. This lady, funny enough, Flavia is she is my special assistant. She deals with my schedule. So if she tells me I can do it, then maybe I can. So she'll get the information and put it there. No, but so I started, again, I mean, I already said it, right? I started teaching college in 1999. I was a graduate teaching fellow, and I love being in front of a classroom. Like, the only reason I didn't go for it full time is, number one, because at some point I needed to pay the bills. and I couldn't, and I had to just do full-time work as opposed to doing a graduate student. And second, even though I love being in front of a classroom, like, the writing is just too much for me. Like, the writing was just not something I could do. So I take off my hat to all of you, doctors, all the PhDs here. It's wonderful. Anyway, yes.
Hi. So, like you, I long for my old class. I'm retired 8 years after teaching at Brooklyn College for 42 years. You said a few things I had in my notes, just transition. So we're sort of on the same page of, people are used to that language.
Yes.
So I think it's good language to use. You said earlier that the employer will pay this, no less than they've been paying, and the worker will pay no more than they've been paying. That implies to me that it's not tax-based, but that it's still employer-based. That seemed very confusing to me. Maybe I'm just hearing.
I was referring to a payroll tax, And so the payroll tax, and those are for folks who are employed, obviously. People who are not employed, that doesn't apply to them. But if folks are employed, then there's a payroll tax, and there's 80% minimum of the payroll tax minimum would be paid by the employer. So basically, if like, in any type of job where there is some sort of health insurance coverage, you have some of it taken out of your check to cover for that, right? So in this case, the 80% minimum of that would be covered by employer as it refers to as referred to in the bill, and 20% maximum of the employee. But again, that can be negotiated. So if it's 100% of the employer, then it's 100% is covered by the employer. So what about that is confusing?
Okay, so it's a payroll tax.
Yes, it's a payroll
not-
tax.
Okay, and so would it be required as a payroll tax for part-time workers as well? Because one of the arguments an employer will make is, "Oh, we don't want to bother to pay your health care insurance, so we're going to keep you under 20 hours so that they can avoid giving health care." But would you still be charging that percentage
If
with part-time workers
it
to
refers to
disincentivize part-time work?
It refers to the payroll tax kicks in after a certain amount. Tony, could you cover this as far as like
Sure.
Go ahead.
Yeah, so the tax exempts the first $25,000 of income, and up to $50,000 of income if the individual qualifies for Medicare. So the tax would kick in after that amount of earnings.
Okay, and then my last question is really one of Myra's questions, which is what happens when you're out of state? How do you
right.
get covered?
So the way that you would get covered and out of state, it would work in the same way that you get now. In other words, you would have a card that would give you if you have an accident, God forbid, but let's say you go hiking somewhere and you get an accident, your insurance coverage, your insurance information is going to be requested from you. The insurance information would be the New York Health Act. So basically that would be then that provider that dealt with you as an emergency would then deal with the state of New York, and then we would pay the bill. course.
You know, most of us here have been for Medicare for all forever.
Yes.
So you're making that real here. And if we
I
can
am-
prove it in New York, it can have strong legs.
That is certainly the plan, ma'am, and it is the hill that I will die on.
Thank you.
I know that, like you, I'm a political scientist. My question then is, I know in the materials on the Health Act that I know the description is a federal waiver would make things easier,
Yes.
but is not necessary.
That's correct.
So I would like a little bit more information about that so that when I'm talking to people who are saying this is impossible, it would be impossible to do it without a federal waiver. What can you talk a little bit more about the dynamics of that? And I mean, and I'm also thinking about like how it alleviates Medicaid, like in that kind of question and that relationship. And this is a strange time, obviously, to be having
Yeah.
this conversation.
This is certainly a strange time, but I think the most important time, because we have to, I think we have to be bold in moments like this, like, you know, and so, but as far as a federal waiver, so the way that it works is that if you have you get from the federal government we seek waivers to say to them, we're going to be using, like Medicaid, for example. Medicaid is usually a system that's like 50-50 roughly, state dollars and federal dollars. And so we say to them, hey, we want to use federal dollars in this creative way. Could you give us a waiver to allow us to do that? So this would be, if we get a waiver from the feds, then it would be easy enough to do. If we don't get a waiver, what happens is the savings become less, but the way that you would do it is that you have to build a system in the back end that can demonstrate to the feds that no federal dollars are going for non-federally approved purposes. The reality is that within the New York Health Act, there's a whole host of things which will be covered, which are already covered by Medicaid and that we have waivers for. But if you can demonstrate to the feds, this federal dollar did not go to a non-federally approved purpose, and you just build a back-end system to be able to do that, then it will cost in the savings because you have to build a system to do that. But that would be the way that we would do it.
Because in the current state-federal partnership that funds both Medicaid and Medicare, that's already part of the agreement.
To be able to pay for this, we need Medicare and Medicaid dollars as well as the payroll
No,
tax
for
to go
sure.
into.
No,
Yeah.
absolutely. I'm talking about like, because people will say like, would the state be permitted to fund it in this way? But that would already be, you're saying
The
that would
state-
essentially be authorized to do that.
No, the state can do with its money whatever it wants. Like we can, if you can get it approved in this by the state level, we can do whatever we want with it. I mean, the reason we don't is because usually, you know, if we want to spend in Medicaid, then it's $1, you know, then the state share would equal $2 total. So we would stick to those because that's obviously cheaper for us. But we can cover whatever we want. We don't because it would be more expensive. But in this case, again, as long as we can demonstrate, and I'll have Tony chime in as well because he can speak to more of the technical terms, but as long as we can demonstrate that no federal dollars are being used for non-federally approved purposes, we would be fine. Tony.
Yeah, and I mean, honestly, I think you described it well, and it's basically like that. Like if there's someone that's, we'll use Medicaid as the hypothetical. If there's someone who's eligible for Medicaid services, a Medicaid covered benefit, we're just making sure that like the dollars coming from the feds are going to support those, you know, that Medicaid eligible person, those Medicaid eligible benefits, and then the state is, you know, using the additional resources it's gathered outside of the Medicaid program to fund any services that may not be covered by Medicaid and to cover populations that may not be Medicaid eligible. And you could take Medicaid and sort of plug in any sort of federal program into that space. You could Medicare, Child Health Plus, the Essential Plan. It would function similarly.
I don't know if there's somebody in the, is there only one? Is Danny Koplowitz the only person online? Oh, there's like 15 or 20 people. Gotcha. You're streaming. Woo, streaming. Gotcha. No worries. Are there any questions? Are there any questions from can they ask questions they can't? So just like scream at your screen and maybe I'll hear you. No, I'm just messing with you. Okay. Yes, ma'am.
I think this is probably more a question for us than it is for you.
Is it on?
Seems to me the prime obstacle.
Is it on? Ma'am, the button is down here.
Is it on?
There you go.
Yeah. The prime obstacle, because I think the New York Health Act
should be law. That's what we need. But the prime obstacle of other public service unions is twofold. First, they have, especially the largest unions and that control the MLC, they have absolutely accepted the austerity from the state and the city that we can't get anything more. And they're always ready to raid whatever and then try to sell it afterwards. That's what we've seen, and that's where Medicare Disadvantage came from. The other obstacle is post-Janus. Some unions, not like the PSC, do not have any engagement with their rank and file. So the only thing they can point to keep union members is health insurance. And they are terrified that if they're not delivering that, if people get that just because they are New York City residents, there's no reason to pay union dues. That's what, they'll never say it out loud, but that's the problem.
And I wouldn't disagree with you. I think, but I think that there is a, these are obstacles that I think that if we get some of the larger, the ones that I'm focusing on right now, CSEA is lost in the shuffle. I don't know. I'll never be able to get them. Like, I know that for a fact. But DC 37 and UFT and NYSIT, I think I got an in. More with NYSIT and UFT than with DC 37, honestly. But I think that there's still an in. And I think that there's like some, and I will continue. And the thing is that a lot of it has to do also with members internally pushing their leadership, right? And that's something I can't do, right? I can educate folks in the rank and file, and the rank and file's got to do what they got to do. But again, I think it's essential for us to get it done. And this is why, again, this is the hill I'll die on. It's like listen, to tell a very long story short, I never intended to do this. I intended to be in front of a classroom for the rest of my life. That's what I wanted to do. I love being in front of a classroom. I wanted to be there. A friend of mine who was also a graduate teaching fellow ran for office in 2000. He got 2001. He got completely destroyed and demolished, but it was the first time that I did political organizing. And I became like, I wanted to continue in public service, but I never wanted to be in the front. The situation happened. A guy who eventually, after I defeated him, went to jail, federal prison for 6 years for stealing public money from a Medicaid clinic that he owned in the South Bronx. That's how much of a scumbag he was. That's the reason I ran to begin with. So I figure, since I'm not going to be one of those folks, and there's a lot of people in this business, for lack of a better term, that just do it because they want to be, they want to be cute, they want to have an honorable in front of their name, whatever. That's not why I do this. I do this because I believe that things like this are important to get done legislatively, and I will die on this hill. I'm going to do this thing. I'm going to do this thing. And I'm doing it with your help. So anyway. Wait, what is it? Wait, what's, what, hey, wait, what, okay, bye. See,
Okay.
Hello.
I have, I guess, a follow-up question to what Andrea was saying. And it's I'm kind of pushing on two of your question answers. Because Andrea was saying in uncertain times, people are more fearful of taking risks. And I am for this bill. But the question, can we trust the state to manage it better than our plans? It just has no specific, it has nothing specific, and it's, and then is universal healthcare radical or socialism? No, but I guess my question is, can you give a positive example of a well-run, large system that we could point people to? Because I think everybody in New York City has had the experience of a mediocrely responsive giant system, So just can you talk more about the rhetoric of being bold and taking risks in uncertain times with regard to the management of this?
I think the question that you're asking is one that I don't think most people will ask, to be honest, but it's one that must be answered. Now, the thing is this: I don't think the type of questions you will ask as an academic about, and then somebody, if you're a political scientist or if you know anything about how governments are run, then you can ask more specific and more deep questions about this the operational aspect of it. Trust me, it drives me freaking nuts. And I'll be honest with you, there are times when I am very concerned that it can't be under this governor. I'm just going to say it. It can't be under this governor. It's got to be somebody else. It's like but I'm not done. Hold on. This is because I know there is a big hurdle to overcome as it relates to the operational aspect of this. It's a way that I'm thinking that regardless of whether I'm in legislature or not, I'm still going to remain involved because I wanted to make sure that it doesn't go off the rails. It's like I'll drag Tony along with me to make sure that the thing doesn't actually, because it is so damn important to get it right. There's some real questions to ask about operational. I'm not there yet. We are not there yet. I will have to answer those questions, but I'm not going to answer those questions yet because we're not there yet. We haven't built enough to get to that point. Once it becomes a political inevitability, the idea that we have to build in people's minds, everybody knows that the healthcare system is screwed, that the healthcare system currently does not serve them. Everybody knows this in the back of their heads. We just have to nudge them so that they can look at it full on and be like, to say that we're going to continue down the road and just kind of tweak around the edges, it's not going to fundamentally change the fact that the core of the system is screwed. I believe that we convince enough people to do that, then we can make it into a political inevitability. It starts to, and again, if we can get if we can get public sector unions to come on board, the boulder will start moving down the hill very, very quickly. And then the implementation of it is going to be a whole other challenge that I'm willing to be in the middle of and tackling, but we're not there yet. But it does concern me, and ultimately it has to be a governor who believes in it. It has to be somebody who says, and again, and this is not, I don't know if this is going up to say, I'm not making any announcements here. I'm making no announcements, but the one thing that I will tell you kind of drives me up a freaking wall and sometimes say, like, I might need to run for governor just to do this, is to actually take the entire, Department of Health and just shuck it out a window and start again. Because there's so many things in there. They're just like, but there has to be somebody who's more willing and committed to the idea. And once you're committed to the concept of it, then you can be like, all right, let's get our hands dirty and figure out how to make sure that this actually operates.
Gustavo, I wondered if you could speak to the board, the notion of a board, right at the center.
Yeah.
I was struck was reviewing some notes, and there was a letter from the Municipal Labor Committee in 2021 to Senate Majority Leader Stuart Cousins that expressed their unqualified objection to the law, to legislation, and for many of the reasons that we've talked about. But one of them had to do with sort of why would we cede control to this board on which we only have this much representation. So I wonder if you could just unpack the idea of the board. And then I'll just throw one last thing in, which is the extent to which experiments in other states in this direction, or attempts or efforts in other states, have come into your thinking or your negotiations with your colleagues or other policymakers.
So as far as the board, there's a board that would be put together for a transition, which is different than the board that would run the system. So there would be a transition board, and there would be a system, and there would be a board that would that would run the system. Labor representation on it is determined at a certain rate. Tony's going to look it up in a second, so he can tell you the exact number of board seats that would be. However, there's some specifically carved out seats that would be specifically for labor, but it does not preclude that there are other seats which are carved out for other professions, which might be unionized themselves. And so you might have union members that way, but not directly from not labor representative per se. And it is true that it would no longer be solely in the purview of that particular, or in this case, the Municipal Labor Council, of that group of folks to determine what happens for their members. Instead, it would be them along with everybody else on the board, determining a system that would serve everybody on that board, their families, and everybody in the state of New York. So this is not something you're not doing a system for somebody else. It would be a system that is going to impact everybody, right? But it is true. Some folks, like it was stated earlier by a sister over here, like they just don't want to do that. They don't want to give it up, and they were like, "We got it. It's the only thing that we got that we can offer our members, so we're not going to give it up." I'm like, I can't do anything to that, you know. And then what's the breakdown, Tony?
Sure. Do you want me to run through the entire thing or just organized labor?
Yeah, quickly.
Okay. So I'll start off with organized labor. There's 3 representatives of organized labor. There's 6 representatives of healthcare consumer patient advocacy groups, 3 representative professional organization physicians.
All of this, by the way, you can write it down, but it's in the bill. We can refer to the section of the bill, so you don't have to write it down everything. We can certainly give you this. Keep going.
Sure.
Keep going,
Sorry, there was a hiccup there. There are 5 representatives of other healthcare professionals, aside from physicians. 3 representatives of general hospitals. 1 of those has to be a public hospital. 1 representative of community health centers. 2 representatives of rehab or home care providers. 2 representatives of behavioral or mental health or disability services, and 2 representatives of healthcare organizations. Healthcare organization can be a labor union, an entity affiliated with a labor union, an accountable care organization, or an accountable care organization that is structured as a nonprofit. 2 folks from healthcare finance, 2 representatives of employers, and then there's 14 separate appointees made by the legislature. 5 from the speaker, 5 from the temporary president of the Senate, and 2 each from both of the minority leaders in each of those houses. And that is altogether, it's a 45 board. And then there's also the commissioner of health, the commissioner or the superintendent of DFS, and the director of budget that serve as ex officio members on the board.
So it's not a small board, but the goal here was to balance out as best as we could all the different interests that would be involved in determining what the system looks like. But again, every single one of those members would be covered by the same system that they're putting into place. The decisions that they're making related to coverage, the decisions that they're making related to rates, the decisions that they're making related to everything else is something that's going to impact not only New Yorkers, but themselves as well. And there's something to be said about that. If you're making a decision about a system that impacts you, and in this case, for example, you and your members, there's going to be some decisions that you're making, right? That are, they're going to be your members in tech. There are some folks who are not in organized labor who are not willing to give that up. And all I can tell you is that if you want something that impacts everybody and creates a higher floor for everybody, then we need something like this.
And what about the other states? Are there other there projects, initiatives at other states?
So the only state where this has passed, where it was about to be implemented and it did not go through, was Vermont. And it was the governor who decided ultimately not to put it into effect. Part of it was because they didn't have the financing it wasn't as thought out as we have been doing, and we have been doing a lot more work. In the case of California, a few years ago, it passed in the state Senate and it failed in the state House, and part of that has to do with some idiosyncrasies of California. There is no requirement. This blew my freaking mind. There is no requirement in California that there be a same as bill. The state of New York, if we have a bill in the Senate, we have to have a same as bill, which means a bill with exactly the same wording in the Assembly to pass to then the governor to sign it. There's no such requirement in the Assembly, in the state of California. Therefore, they have like conference committees, et cetera. What happened there was a push politically internally in the Senate to get it passed. So without thinking through the whole financing structure of it, they passed it and they threw it into the Assembly's hands. And when it got to the Assembly's hands, the governor was like, this is going to cost way too much. It hadn't been thought through completely. It ultimately fell apart. And it just didn't. I think that we have made There have been, I will tell you that I am working along with legislators in like 6 or 7 other states who are doing versions of this that are trying to like, that are also trying to, that have introduced versions of single payer systems in their states and are building, we're far ahead of them. This is, I mean, and again, we can be the vanguard of it. And because we're so large, because there's so many interests here, because we are a wealthy state, many of the wealthy interests that would be impacted by this, some of them live here. It makes it more difficult, but that just makes it even more delicious when we win.
Maybe one more comment, question. Can someone pass a microphone to the gentleman?
Yeah.
If this system actually went into effect.
I think it's on. Oh, you have to hit it one more so it's green. On the bottom there.
Okay, is this okay? All right. If this actually went into effect, would it, how would it handle commuters, say, who live in New Jersey and work for companies in New York? And I mean, because I can imagine if they were not included, then each company in New York, which has.
If you're an employee, I'll stop you. If you're an employee in the state, if you're full-time employed in the state of New York, you're eligible. Even if
Okay.
you reside in New Jersey.
Oh, I see. Okay. Mm-hmm. Yeah, thank you. I was envisioning maybe there'd be a demographic shift of people moving into New York just to get this, and then there
By
might
the way,
be,
there
there might
is-
be doctors who moved out of New York so they could charge whatever they want.
See, but nah, hold. There's like some of the opposition can't get their damn story straight. Not you're not saying this about you, but it's like, well, this is going to lead to a whole bunch of people moving to the state to seek out this benefit. I would argue that is a good thing because to get this, you would actually have to live here, be employed here, be able to be a resident here. All those things are to be established. So therefore, you wouldn't just be moving to get something for free. You would actually be benefiting from something that you're actually paying into, because it actually, if you're employed here, you get the payroll tax, et cetera, et cetera, et cetera. But then at the same time, those same critics are like, but it's going to lead to a whole bunch of people leaving the state because they're not going to. So I was like, folks, get your damn story straight. Are they going to leave the state? No, a bunch of them. Are they going to come into the state? So there's a lot of this stuff. Because I know that you want to bring it in for landing. I will say this: it is a very complicated thing more than anything else, because we are living in uncertain times, and the idea that people are wanting to risk, the people that want to, it seems like it's a far-fetched idea, but the thing is, this is why we have to repeat to people over and over again, it's not a far-fetched idea. There's a version of it that exists everywhere. And we can get it done here. We need to get it done here, because continuing down the road with the system that we have right now will never give us good healthcare. It doesn't. That's not what it's built for. Again, it's that scorpion. With your help, I want to snatch that scorpion off the back and squish that bastard.
Let's thank Senator Rivera and his colleagues for coming in today. Thank you so much.
Yes. Thank you to everybody. Thank you to everybody on the thing. Bye-bye, Tony.